Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks to you all for joining the conversation. I'm going to go through some of this more quickly because we did talk to many of you some months ago after our first presentation of the results at the AIDS 2022 conference. And then there have been some updates from our group and new study results that I'll highlight and then pass it to Julie to talk about where we are and thinking about implementation. So in terms of disclosures, we did get donation of doxycycline from Maine Pharmaceuticals and lab supplies for the nucleic acid testing from Cepheid and Hologic. And this was funded by the NIH, DMID, and we very much appreciate their support. And just once again to recognize that there are many things we don't have time to go into in terms of how race and racism impact STI disparities, among many other things. But the reason why we did the study is that we're now into, I believe it's year 7 of very steady increases in STIs. And these are the numbers from 2020 from the CDC. And really, we didn't see a huge decrease due to COVID. And so even in the context of COVID, where we knew people were not seeking care for some issues like STIs, the numbers continue to increase. And this is in the context of the CDC's main approach, which is to talk to your partners, talk to your providers, get tested and treat. So this approach doesn't seem like it's not leading to decreases in STIs. I think that's the best we can say. And we're really concerned by, and these are data from the last couple of decades in the top 2 panels in terms of GC and chlamydia, where in blue it shows the rate per 100,000 going up considerably among men who have sex with men for both gonorrhea and chlamydia. And then below, these are cases, not rates, of syphilis, and just showing that MSM account for a sizable majority. Some of this is probably related to increased testing in the context of PrEP programs since 2012. So I'm going to give you a little bit of background about Doxy. And the first study that was done was in France, and that was called it was a sub-study nested within the event-driven HIV PrEP study called IPRGay. So smallish study and 232 men, and basically they gave enough doxy for up to 3 times per week dosing. The median amount taken was 660, so about 3 doses per month, and they saw about a 2/3 reduction overall in chlamydia and syphilis and no reduction in gonorrhea in that first study. It was published in Lancet in 2018. Stirred the pot a bit, but people felt like they wanted more data before it would be implemented more broadly. And around that time, about 2018, 2019, we started thinking about, well, perhaps more data we could contribute to this. And again, decided to focus on doxycycline based on this promising data from IPRGay. And we wanted to see whether in a larger population, including men living with HIV, because the IPRGay study was just in MSM taking event-driven HIV PrEP, whether DoxyPEP would reduce gonorrhea, chlamydia, and syphilis, and also to learn about antimicrobial resistance, because the first study really had limited ability to look at that. And you might ask, well, why doxycycline? And it's really because of its safety, its tolerability, its low cost in a number of different generic formulations, and very high activity against both chlamydia and syphilis without any evidence of inducing resistance. And that some gonorrhea have resistance. We know that it's about 1 out of 4 isolates, 1 out of 5 in the US, and over 60% in France. We didn't know how well doxy would work against gonorrhea given this, but felt like it was an important question to ask. So the way DoxyPEP was designed was We enrolled 2 cohorts of men who have sex with men and transgender women living with HIV, and those on HIV PrEP. We planned for similar sized cohorts with a 2-to-1 randomization to take DoxyPEP within 24 to 72 hours after condomless sex, with the instructions not to take more than 200 milligrams every 24 hours. We enrolled men who were male sex at birth, had 1 or more STIs in the past 12 months, and had ongoing condomless sex with at least 1 man in the last 12 months, did quarterly 3-site STI testing and RPR serologies, and tried hard to get gonorrhea cultures to look for antimicrobial resistance before they were treated. Did this study in 2 HIV clinics and 2 sexual health clinics in San Francisco and Seattle, so a total of 4 clinics. We were stopped early due to efficacy, and we presented those data after we were unblinded on the first 501 participants who had at least 1 quarter of follow-up. You can see that their median age was about 36 in the PrEP cohort, about 43 in the men and transgender women living with HIV. We had about twice as many participants on PrEP as living with HIV. Fairly diverse cohort in terms of about a third were either Latinx or Black or Asian Pacific Islander. Almost all were men who are having sex with men and were not trans women, harder than we had envisioned to recruit that group. And in the last 12 months, over 2/3 had had gonorrhea, over half had had chlamydia, and about 1 out of 5 had syphilis. This was a very sexually active cohort. The median number of partners was 9, and also recreational drug use was pretty high. So these are the primary data that we had designed the study expecting about 10% incidence of STIs, and found actually in the control arm it was about almost 30, a little over 30% per quarter. So high incidence of STIs, and we reduced it by about 2/3 in both cohorts in these 2 panels, and then summarized on the right here. Most common STI was gonorrhea in blue, chlamydia in orange, syphilis in green, and more than 1 STI in the black panels. This shows the data broken down both by STI and anatomic site. What you can see is that the light color is urethral, and we had very little urethral gonorrhea or chlamydia. Most was either pharyngeal or rectal. And then we had about a third of participants with gonorrhea had 2 or more sites, and only 14 cases of incident syphilis. And again, we were stopped early, so we had hoped we would have more power to look at syphilis, but even with this small number of cases, you can see on the right that for all of these subgroups, except for persons with HIV with syphilis, these were highly statistically significant reductions. So we mentioned earlier, the median number of partners was 9, and 5 sex acts per month reported in enrollment, and almost all, 90% of sex was reported as condomless. I'm not showing you detailed behavioral data, but we've looked at it in a lot of different ways. And we found no evidence of what some people call risk compensation in terms of either more partners or more condomless sex during follow-up. Adherence appeared to be pretty high. 86% of participants in the DoxyPEP arm reported that they always or often took it after vaginal sex. Median number of doses was 4 per month. And there was a subset, about a quarter, who took at least 10 doses per month. So there's some trade-offs here. Because we saw less gonorrhea, there was, not surprisingly, less ceftriaxone use, about 50% less in the DoxyPEP arm. We saw we looked at this in terms of reductions in STIs that were symptomatic versus not. And basically, no matter how we looked at it, there was a reduction both in symptomatic and asymptomatic infections in the DoxyPEP arm. There's been a lot of discussion, I think Hillary alluded to this, around the controversies center around antimicrobial resistance and impact on the microbiome. I'll show you what we have and what others have presented. This is a busy slide, but the point just being that we were able down here in this culture collected arm, out of all the GC at baseline or during follow-up, we got roughly about a little over a half cultured for those that came to the study site, but some of our participants were in Kaiser and it was much harder to get them in before treatment. So overall, it was about 49% across the whole population, both baseline and follow-up, where we had GC culture. Of that, only 40% grew. Believe it or not, GC is a fickle little bug. And you can see that you're less likely to grow it if you culture it from the pharynx or rectum. So from all these GC cases, we have antimicrobial resistance data in about 56 participants. And what you can see on this slide is that at baseline, the dark color at the top is high level of resistance, defined as an MIC greater than 16 to tetracycline. And the blue teal color is intermediate resistance, and yellow is no resistance. So at baseline, that's the distribution where about 24% had either intermediate or high level. In the standard of care arm, it was 11% after enrollment. This is still at baseline. And you can see that there was some maldistribution. Sorry, I'm wrong about this. The two right-hand panels are incident SGC cases, and you can see that there was a little more resistance to tetracycline for cases of gonorrhea after enrollment, but it's really limited. You can just see in the parentheses how small the numbers are, in spite of a lot of effort to get these men cultured. We also looked at Staph aureus because staph can cause soft tissue infections, and we know is a pretty common. First of all, just interesting to see that we saw almost half of men at enrollment were colonized with Staph aureus, and we did oral and nasal pharyngeal cultures. And over in the DoxyPEP arm, in these green panels over here on the right, you can see that we saw a reduction in the proportion who are colonized. So Doxy-PEP reduced colonization with staph, and it was about a 14% reduction. Looking at tetracycline resistance, because we reduced the amount of Staph aureus colonization, it's important to look at both relative reductions and absolute changes in resistance. And the net effect is that there was an 8% absolute increase in resistance to doxy in the DoxyPEP arm from baseline. So small percentage increase, not sure that would be clinically significant, but again, the numbers, it's only maximum of 12 months of use of DoxyPEP. We did not see we saw very little. As you can see here, the scale has changed, but about 5% had MRSA at baseline, and we did not see a significant increase in MRSA resistant to doxy over time in the DoxyPEP arm. I think it's really important to capture the perspectives of the participants, and we did have an important qualitative component. This will be presented in a couple of months in Brisbane at the IS meeting. We sampled 44 participants from the DoxyPEP arm with one-to-one interviews, face-to-face interviews, really face-to-face by Zoom in most cases. We tried to oversample racial and ethnic minorities, and about half were living with HIV, and almost half were either Black or Hispanic. And I think the key themes to be aware of is that the participants we interviewed reported that taking DoxyPEP gave them more sexual pleasure and peace of mind. They did not perceive it to have changed their sexual behavior, just kind of their comfort and confidence with being sexually active, and especially if they were not using condoms. And there was a sense of that it was empowering to them, that they felt like they were being proactive, responsible about their health, also doing something to contribute to STI reduction in their community. And many reported that they were aware of the risk of antimicrobial resistance, but it was not a barrier to their use. So just to wrap up on our study, we found that it reduced STIs by about 2/3 in a context of a population that had a very high risk of STIs. About 30% of the cohort had one or more STI per quarter in the standard of care arm. It prevented each bacterial STI, including gonorrhea. You need to treat 5 people to prevent a quarter with an STI. So from a prevention perspective, when you think about statins and other things, this is a pretty low number needed to treat. I didn't show you a lot on this, but it was very safe and well tolerated. We had like 2 participants discontinue it. Adherence was high, acceptability was high, and there were trade-offs. More doxy exposure, less ceftriaxone exposure. And the risks that we continue to discuss, and I think providers discuss this more than the community, but we just had a community forum last night, and the community is also talking about microbiome and antimicrobial resistance. We haven't seen it. We have preliminary data that we're still analyzing on the gut microbiome, and it does not give a strong signal of changing the flora, but it's complicated to do these kind of microbiome analyses, and we need more data with longer doxy use. And we're looking and haven't seen it yet, but we have not seen any resistance in incident chlamydia for those that we were able to culture. I showed you the gonorrhea date. We don't anticipate it with syphilis, but we're trying to look at that with molecular techniques. And eventually we'll look at it with Mycoplasma genitalium. We were worried about so-called risk compensation and changes in sexual behavior, but we didn't see it. So just real quickly, and then I'll turn it over to Julie, the data that were presented at CROI in February, new data came from the French group, study called Doxy-PEP, where they were interested both in looking at Doxy-PEP on gonorrhea, chlamydia, and syphilis, and then Bexsero, for valent meningococcal B vaccine on GC. They did a factorial design, and I'm just going to report on the Doxy-PEP part. They were unblinded by their DSMB after our data were presented in July 2022, and they had a very similar number, about 500 analyzed, similar follow-up, about 9 months, similar age, similar sexual activity, and they are still digging into the Bexsero data because I think they were audited by, and there's something that it's not clear to me, but we need to wait and see what the final results are of the Bexsero vaccine. But for Doxy-PEP, they found very similar reductions, over 80% reduction in chlamydia and syphilis, even a little higher than ours. This was all, again, HIV uninfected men. They did not have a cohort of men living with HIV, and about a 50% reduction in GC. So we now have 2 out of 3 studies showing reduction in GC and 3 out of 3 showing reductions in chlamydia and syphilis among men who have sex with men. They also tried hard to get GC tetracycline resistance, and there's maybe, again, the numbers are really small, a third of 21, 20% out of 37. So maybe a little trend towards more tetracycline resistance. In the incident GC cases, they tried to look at chlamydia and they didn't see any, but none of the cultures they were able to grow were from the Doxy-PEP arm. They looked at MRSA, again, low prevalence, no change in MRSA with resistance or detection of MRSA by arm. They also looked at ESBL E. coli, and there was no significant difference by arm. Lastly, the last study that was presented from our colleagues at UW and Kimry did a study in cisgender women in Kenya with about 400 women, 1-to-1 randomization, and very disappointing and not fully understood yet, but they saw no reduction. And these were women who were on PrEP, and they censored for time that they missed doxy due to being pregnant, and they still didn't find a reduction. Maybe a trend for chlamydia, but it's not significant. And they're looking to try to unpack this to see if it's, could it be biologic? Maybe. It seems a little hard for me to imagine the biology. Chlamydia, is that different in the endocervix versus the rectum and pharynx? But also maybe different exposures. Maybe, I think many people are assuming it will end up being adherence. This was done in a setting where there's not STI testing. Most women are not aware of their past STI history because there isn't diagnostic testing. So stay tuned for more data. So just to wrap up, there's a lot of discussion. We're waiting for CDC guidelines, which I think are going to be coming out soon. You know, one question that people have raised is, will gonorrhea become resistant to doxy? And we think that yes, it's possible, probable, but we don't use doxy for GC. And it may take years, and it'll depend on how many people use DoxyPEP. Will we induce resistance in other organisms? I've showed you the data from Staph aureus. We saw, you know, like a 14% increase in tetracycline resistance in staph, but it's, you know, is that clinically significant? We don't know. We did not look at strep pneumo, but that would be another organism where we use doxy for community-acquired pneumonias, and we will look at this in a planned implementation study. Don't expect to see it in chlamydia, syphilis, may see it in Mycoplasma genitalium, but we need to look. Haven't, you know, the French group looked, didn't see it in E. coli, but we need to look at it. Will it alter the microbiome? Maybe, but maybe transiently. This is a hard question to ask, and the MSM, one of our colleagues, Dr. Colleen Kelly at Emory, has looked at the microbiome in MSM, and we know that anal sex itself just alters it, as well as lube use and other exposures. So we'll have to look at this, but I think I just want people to be aware that we probably won't have answers for some time. We don't think, I think most of us don't think that DoxyPEP is going to really impair use of other drugs in the tetracycline class, which are not used very often, but it is an understandable concern. And then we need math modeling to really help us understand whether DoxyPEP will reduce STIs on a population basis, and whether in the end it will be a antibiotic sparing approach, at least for ceftriaxone. And a key aspect is that we learned over the past decade that HIV PrEP was not delivered equitably. Will that be the case for doxy? It could be, and we really need to try to be very intentional about this and see if we can reach underrepresented minority MSM and transgender women. And that will be a focus of the grant that we put in recently to look at DoxyPEP implementation in Seattle, San Francisco, Atlanta, Detroit, and Miami. I'm going to end and just thank the many people who've contributed to this study. It's been really a team effort, and everyone had a very significant role to play, and we appreciate particularly the participants who volunteered their time and showed their commitment and have taught us so much. So I'll stop sharing and turn it over to Julie.
Great, thank you so much, Connie. And I will share my screen, and I am probably going to give just a brief overview so we can move to discussion pretty quickly. So focusing on implementation, we were last talking to you in August of last year when we didn't know at all how this was going to be implemented. My disclosures, by the way, are the same as Connie's. And now we have some guidelines from a smattering of places, essentially all in California: San Francisco, Santa Clara, Alameda County, that's Oakland, and California State. We have pending local guidelines here in Seattle, King County. There are no CDC guidelines yet. My best knowledge is they're coming, but I really don't know when and have no idea what those will say. And important to keep in mind as we're putting together this implementation guidance that people are already using DoxyPEP. Some providers are prescribing it. People get a hold of it when they hear about it and are interested. And just as one data point on that, in our annual Pride survey in Seattle last year, 11% of MSM who were surveyed reported using DoxyPEP or DoxyPrep. So I assume that will only go up. Important to think about. So San Francisco was the first place to put out guidelines, and that was in October of last year. And the key points that I'm going to highlight and then show you in the others is they recommended DoxyPEP to people who would have met the criteria for the study, as you can see there. They also recommended offering DoxyPEP using shared decision-making to the same population who had not had STIs in the past year. So this goes beyond the data that Connie presented to you in our study. And my understanding of the rationale here was ensuring that people who hadn't had access to healthcare or hadn't had diagnoses could still have access to DoxyPEP. And at that time, this was before the DPEP study in cisgender women. They essentially said insufficient evidence to recommend for people who have receptive vaginal sex. Alameda County put out somewhat similar ones, but again, a little less strong of a recommendation. This was in February of this year, where they recommended that healthcare providers should counsel MSM and trans women about DoxyPEP, and that people who were interested in it and met the study criteria should be offered it. So those are some subtleties in language, but I do think it says a lot about some of the controversies in the public health field, in particular in the STI field, about the best way to implement this new intervention. Santa Clara County put out recommendations in March, which were very similar to San Francisco's. They recommended DoxyPEP for the study population and still really emphasized shared decision-making for other people who wouldn't have met the study criteria, and again noted insufficient evidence for cisgender women. California, this was a bit of a surprise, at least for me, and I think for many people I know, in April, so just last month, put out guidelines where they recommended DoxyPEP for, again, essentially the study population. And interestingly, they also recommended that healthcare providers offer DoxyPEP using shared decision-making to all non-pregnant individuals at risk of bacterial STIs and people requesting DoxyPEP. So that includes cisgender women. And it was interesting, they just sort of put a footnote, noted the Kenyan results that Connie showed you, and said it was remaining to be seen why that was, including adherence assessments. So that's a surprise, but it is California state. It's a big and important place. It certainly influences practice. So interesting to know that that is there. Our draft guidelines, I want to show you just 4 points. There's a lot of text here, partly because I wanted to show you our exact wording and not summarize it in quite the same way I did as the others. Our draft guidelines, there was a community input process last night, and I think we still are really interested in hearing providers' perspectives. I would also welcome any of yours, are to first and foremost inform the study population. So it's not actually recommending DoxyPEP in the same way that the San Francisco and other California guidelines were. Number 2 is that there should be a shared decision-making process about DoxyPEP for anyone, and that there should be particular consideration for prescribing DoxyPEP to patients with a history of syphilis, history of multiple STIs in the past year, and consider prescribing on an episodic basis when people anticipate higher STI risk, like group sex events, for example. Part 2 of the draft guidelines is explicitly saying not recommended for cisgender women. Our interpretation of the very well conducted study that showed no effect in cisgender women in Kenya is that we should not recommend DoxyPEP for cisgender women at this time. And the 4th point, actually, but second here, is just to point out that we really don't know benefits and risks for transgender men or other people assigned female sex at birth who have anal sex with men. That group hasn't been included in any of the studies, so we could infer and make some guesses, but we don't have data. So in summary, I would say we don't have national guidelines. In the guidelines to date, there's heterogeneity in the strength of recommendation for MSM and trans women, with some clearly recommending it, some saying healthcare providers should offer it, and others recommending healthcare providers inform and make sure that patients who could benefit from DoxyPEP are aware of the studies and the benefits it shows. The variation in recommendations for cis women, as I pointed out, mostly not recommended, but I think we're still really trying to figure out that study and the way forward. And For trans MSM, I think there are varying recommendations, mostly stating no data. All of these have an emphasis on shared decision-making, and we are hoping in King County to put out some clear points for healthcare providers to be able to talk with patients about DoxyPEP and considering their right decision for themselves. So that is all I have, and I'll stop sharing so we can move to discussion.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.